अऊज़ुबिल्लाहिमिनश्शैतानिर्रजीम बिस्मिल्लाहिर्रहमानिर्रहीम अर्रहमान अल्लमल कुरान खलक़ल इंसान अल्लमहुल बयान। आज काफ़ी अरसे के बाद आपसे बात हो रही है। उम्मीद है आप सब लोग खैरियत से होंगे। हमेशा की तरह बात शुरू करने से पहले एक अच्छी बात, इफ़ यू कैन चेंज योर माइंड यू कैन चेंज योर लाइफ। So remember, you have to change your mind and you will make sure that you should have the idea of seeing yourself successful. आज का जो टॉपिक है theoretical टॉपिक है. It's an acute confusional state. It's most like a clinical dilemma or a diagnostic dilemma rather than a pure theoretical topic. So सबसे पहले definition, acute confusional state also known as delirium is a transient fluctuating disturbance of consciousness and cognition. It is characterized by impaired attention, disorientation, disturbed perception and altered sleep-wake cycle. It's more common in critically ill children, especially in ICU settings. It is significant because it is a neurological emergency, often a manifestation of underlying systemic or CNS pathology. The patient can present with acute onset within hours to days. It may have a fluctuating course during the day. There will be impaired attention and awareness. The patient will be disoriented to time, place, or person. There will be hallucination of visual and auditory. The patient can be agitated or having a hyperactivity. There will be sleep disturbances, sleep-wake sleep cycle disturbed, and the speech will be incoherent or the patient will be mute. So you have to see in some things and ask something in the history like the onset and progression, whether the acute confusional state was sudden or gradual. Is there any recent history of fever, and has the patient taken any anticholinergics, anticonvulsants or sedatives? Is there any toxin exposure such as household chemicals, lead, etc.? Is there any metabolic disorder like diabetes, decay, inborn errors of metabolism? Is there seizure history in the family or the child? Is there any trauma or head injury? Is there any travel or infection exposure to the child? And is there previous psychiatric history or prior episodes? So now come to the examination. The patient will be looking sick, may have respiratory distress at rest, or the child can be severely jaundiced or pale. The child will be febrile, may be hypotensive and hypoxic. So in a systemic examination, you see the level of consciousness, AVPU or GCS. So neurological exam, you check the pupils, tone, power, reflexes and signs of raised ICP and meningeal irritation. You have to check for the signs of systemic illness by checking for hepatomegaly, for the Rice syndrome, jaundice, dehydration, petechiae rash, fundus exam for papillary edema, and look for focal neurological deficits. There's a list of differential diagnoses from system-wise. In CNS infection, rule out meningitis, encephalitis. If the seizure related, then it can be post-ictal or non-convulsive status epilepticus. In cases of metabolic syndromes, rule out hypoglycemia, hyponatremia, hyperammonemia. Toxicological causes include accidental ingestion poisoning, and intracranial hemorrhage can be a result of traumatic cause. Acute psychosis, which is very rare in young children. Other systemic causes that can cause acute confusional state include sepsis, hepatic encephalopathy, renal failure, and autoimmune encephalitis. So investigations, the specific investigations include toxicology screen, lumbar puncture if you are suspecting meningitis and there is no signs of raised ICP, EEG to rule out non-convulsive status epilepticus, neuroimaging such as CT and MRI if trauma, focal signs or raised ICP suspected, ammonium lactate and ABG for metabolic causes, blood culture, CSF culture, drug levels if on anti-epileptic drugs or suspicion of overdose. So the supporting investigations are such as the blood, CBC, electrolytes, LFTs, RFTs, glucose and calcium. So treatment, the supportive measures include pass IV line, maintain hydration and oxygenation, monitor vitals and neurological status. nutrition support, maintain hydration, oxygenation, sorry for the repetition, environmental control, calm well-lit child, reduce sensory overload, medications only if necessary. Remember to avoid sedatives, consider haloperidol or risperidone for severe agitation, family education and support. So specific antibiotics treat the underlying cause like infection, IV antibiotics or antivirals, metabolic disturbances, correct glucose, sodium and calcium, toxic ingestions like decontamination, antidotes as needed. For seizures, antiepileptics, manage status epilepticus. Monitoring the intake and output monitoring, diet, depending upon the condition and diagnosis. Activity is a condition specific, so complication follow up as per the diagnosis. So since acute confusion state is a symptom, so prognosis depends upon the diagnosis. In summary, acute confusion state is a symptom, not a diagnosis. Rapid recognition and targeted management can be life and provide long-term neurological sequence. Always consider life-threatening causes. First stabilize the child and then proceed with a focused diagnostic approach. Thank you very much for your listening, and we'll be looking forward for your feedback. And next topic will be acute hepatitis, which will be followed by the MCQs. So I'll try that. I should make some MCQs for you people so that you should also learn and have practice of the MCQs. May Allah be our helper, protector and guide. Allah Hafiz.